My pleasure to introduce next Dr. Elizabeth Jaffee. Dr. Jaffee is the Dana and Albert Broccoli Professor of Oncology and the Deputy Director of the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. She's well known for her research in advancing translational medicine and research in cancer immunotherapies, and today is going to tell us about vaccine-induced immunity against non-viral cancer genes to prevent pancreatic cancer. Dr. Jaffee.
Thank you. Well, it's really a pleasure to be here. And so I just have to admit to all of you that I'm really a cancer immunologist by training, an oncologist, and this is really the beginning for me to join the world of prevention. But as many people have said today, I think that prevention really is where we have to focus our efforts if we're really going to impact patients for the future. So I'm going to be talking to you about trying to target non-viral associated cancers for prevention with immunotherapy or vaccines. So this is very different from what you heard from Dr. Lowy, where typically when you're trying to target a virus, you're inducing antibody responses to neutralize the virus. In this case, really we're talking about the cellular responses. In particular, we need to induce T cells because the changes are already occurring in a cell, and so the T cell is going to be much more efficient at being able to recognize those changes. So I just wanted to make that clear that it's a different area, a different expertise that you need to understand here when you try to do this. So this is my disclosure information. And so I'm going to start. So I target, I'm going to talk about pancreatic cancer. I've been working in pancreatic cancer for many years. What really makes me very sad, actually, is that it's still among the deadliest cancers. Even though it's not one of the most common, it is one of the most deadly. And if you take a look at the survival curve, it really has not changed long term. We do have some chemotherapies that have improved the overall survival for over months. But by 1 year, again, that curve really comes sharply down, and most patients will die of their disease pretty quickly. What is interesting is that recent genetic data has suggested that it metastasizes early, even at the time of pre-malignancy. So this is also important because this, again, makes a case for trying to target this in prevention. And so again, prevention may be the best way to affect this disease. A couple of facts about pancreatic cancer. So it is considered non-immunogenic typically. Some people call it a cold tumor versus a hot tumor. But the reality is it's really not cold. It has inflammation, but most of the inflammation that you see when you take a cancer out, a pancreatic cancer out, is really regulatory T cells. Or regulatory myeloid cells. What you don't see are the effector T cells that you might see in a cancer that's immunogenic, such as melanoma. What is interesting, though, and we're learning this from genetically engineered mouse models, thank you, Tyler, and all the other people who have really developed this field, is that it's really, cancer is not just a genetic process, it's really a genetic and inflammatory process. And also, what we also know is that, as I mentioned, when you take out this cancer, you really have a hard time finding effector T cells. And so the tumor microenvironment is really critical, or the pre-malignant microenvironment is really critical to understand before we're going to have effective therapies for this cancer. And so I like to show this slide because what it really points out is that pancreatic cancer really begins with a genetic alteration that's the driver gene in most cases, and that's mutated KRAS. And at the earliest genetic change, you already start to see this inflammation coming in to the pre-malignancy. And this typically starts out as cells that could react against the earliest changes, but they quickly change their functional polarity. And it's composed of macrophages, neutrophils, regulatory T cells, even early in the earliest pannin, which is what occurs with the first mutation. As these mutations accumulate, you get more accumulation of this inflammation, and they become more polarized toward a pro-carcinogenic response. And so there's been some data from a number of my colleagues, Lisa Cousins, Daphne Barsagi, and then Bob Vonderheide and I have also contributed to some of this, showing that these genetic alterations actually have pathways that attract the inflammation. So what Lisa and Daphne have shown is that IL-8 is actually a transcriptional target of mutated KRAS. And so with IL-8, what you then have is you have the attraction of neutrophils, macrophages, and mast cells because it acts as a chemokine to attract these cells into the microenvironment. GM-CSF is also a down signal of the mutated KRAS. And when GM-CSF is also secreted in the presence of IL-6, you start to turn macrophages and dendritic cells that could become anti-cancer into ones that promote cancer. And also, it's important to know that IL-8 signals through CXCR1 and CXCR2, again, two chemokines that are going to attract the myeloid cell population. So the other thing I wanted to point out is that there are a number of examples of this progressive inflammation. And so this is looking at data that we published on Ly6G neutrophils and also on F480 positive macrophages. And what you see here is Panin-1s, the earliest lesions. You don't see many of these cells, but as you go to the Panin-2s, they start to progress. And by the time you have the pancreatic cancer that's invasive, you now have a fair number of these cells that are infiltrating. The other important point to know is that we're learning that it's not an all or none phenomenon. If you were to deplete some of these populations, sometimes the cancer will grow even faster because it's really about changing the functional polarity. And so that's really important. So what ideally, as you start to think about how are you going to develop vaccine strategies to prevent progression, what you really need to do is think about vaccines that target important antigens, but also ways to alter the functional polarity of these infiltrating inflammatory cells. And so just to point out, we classify our macrophages, and this is actually a pretty old classification. As new targets are available, we have even more specific classifications, but we have the M1 versus M2. Initially, you might have an M1 phenotype coming into the tumor microenvironment, which is a type of macrophage that would fight infection because they stimulate more of a T helper 1 response. They're very good at antigen processing and presentation, and eventually T-cell activation. However, these eventually turn into M2s, and this could be an epigenetic regulator, this could be a genetic regulator. There are a number of different ways within the tumor microenvironment that this can occur, and so you get these M2s, which now promote more of a T helper 2 response, and these are also going to be more tumor promoting. So we have to consider these types of phenotypes as we start to try to develop approaches that can target in prevention. Now, everyone knows about some of the very exciting data coming out of the treatment of cancer with immunotherapy, and we have a number of antibodies that can alter the signals on T cells in the tumor microenvironment. And this is also an important concept to understand too. So this is your T cell, and this is the antigen-presenting cell in the tumor microenvironment that expresses the ligands for the signals on the T cell that needs to be modified. And it's important to realize that there's not just PD-1 and CTLA-4 on these T cells. What we're learning is that there's many different inhibitory signals and many different activating signals, and it depends on the context of the tumor microenvironment as to what happens with the T cell itself. Now, the other important point is that each signal on the T cells and its receptors have different distinct biological functions. There's no redundancy here. So this may be one reason why there's resistance in some cancers that don't respond to anti-CTLA-4 therapy or anti-PD-1. But also it's important to understand that these pathways may not be the most important when you're thinking about the premalignant premalignant microenvironment. And so the predominant signals may differ with the cancer type, they may differ with the stage, and they may differ whether it's a premalignancy or a malignancy. So emerging concepts have been published that may suggest why a tumor develops. And just I'd like to summarize those. And this comes from Bob Schreiber and some other people in the literature. And I think these are very important concepts to understand because it helps you think about how will you try to alter this environment in order to get an anti-tumor or anti-premalignancy response. And so Bob Schreiber and some of his colleagues have really described this elimination versus immune editing. And what this really is as the tumor starts to accumulate genetic alterations, initially you get this immune surveillance or an immune response that comes in that has the ability to eliminate the transforming tumor. But at some point, the tumor changes are occurring faster than the T cells can adapt, essentially. And so what you end up getting is this equilibrium, and then eventually the tumor wins out and you get escape. Now, this is important because if you have these changing genetic proteins that are being made constantly, it may be very difficult to keep up. So where you may want to be targeting your vaccination is really at the earliest stages of transformation. Now, it sounds easy maybe, but of course we're going to need ways in which to screen, as we learned this morning, to pick out those individuals who are having the earliest changes, because cancer does take 20 to 30 years to develop. So we're still going to need good screening methods in order to identify those populations who will benefit from any immune-based therapies. So this is what a pancreatic cancer looks like when you take it out at the time of surgery, and I just wanted to show you this to point out that you have these tumor islands. In pancreatic cancer, you typically have the stromal reaction. Within the stroma, it's actually a dynamic process, and you have these regulatory cells. I'm showing you FOXP3 T regulatory cells, but you could find myeloid, granulocytic regulatory cells, even B regulatory cells sitting in here. But what you don't usually find, and this is a challenge, you don't find the T cell. And this is why going to prevention may also be the best way to have an effect in this cancer. So we wanted to ask, can Panin progression be slowed by targeting the earliest genetic mutation? In this case, pancreatic cancer actually is a good model because 90% or greater have a particular driver gene, mutated KRAS, and there aren't too many different mutations that we would need to target. And so I'm going to talk a little bit about targeting mutated KRAS in the context of genetically engineered mouse models. And the one we've been working in is the KPC mice that Dave Tuvison published on and had learned to develop, working with Tyler way back. And as you all probably know, this mouse model has a dominant active KRAS mutation with a P53 inactivating mutation. And it's driven by the PDX1 pancreas-specific promoter. And what's nice about it is it does have the stepwise progression from normal to Panin 1 to Panin 2 and 3 to pancreatic cancer. So it really does recapitulate as best as possible the human disease. The other thing to know is that Panins begin between 4 to 6 weeks, and this is important because we want to start to vaccinate at the time that Panins are developing. And so the first thing we did was take a look at the earliest Panins in these mice, and what you see here is something similar to what the cancer looked like. The stroma is already developing, and what you see are these regulatory T cells coming in. You also see the myeloid cells, and you also see the granulocytes coming in, as I had shown you before. But the first thing we wanted to do was see if we alter those regulatory T cells and then vaccinate, can we do better than just vaccinating alone? And so this work was done by an MD PhD student, Dr. Bridget Keenan, who now has gone on to her residency. And we decided to use Listeria monocytogenes as a vector to deliver the mutated KRAS antigen. And we wanted to begin early, targeting the lowest grade Panins, and then also see what happens when you target the later stage Panins. And we compared vaccine alone versus vaccine with regulatory T cell depletion therapy. And so why Listeria? So we've been developing Listeria clinically for the treatment of pancreatic cancer, and it's quite safe. What's nice about it is an intracellular bacterium. This is a live attenuated double-deleted Listeria, so it has no ability to have cell-to-cell propagation, so that makes it safe. Importantly, it actually has both adjuvant properties because it induces an innate response through the toll-like receptors. It also induces IL-12, which is a T helper 1 response. And it also gets its antigen not only into the class 2 processing pathway to help induce T helper cells, but also into the class 1 pathway through Listeria lysine, which lyses open the endosomes to allow antigen access to the cytosol. So it had a lot of reasons why it seems to be a good vaccine for treatment. It's safe, it's exquisitely sensitive to penicillin, so it seems like something we could also use for prevention. So the first question we asked was whether or not we can induce a T-cell response against mutated KRAS in the KPC mice versus the wild-type mice. And what you see here, this is just peripheral number of CD8 T cells producing gamma interferon, so they're functional, and this is in the periphery, and it's pretty equivalent. We don't see anything in unvaccinated mice. So the next thing we asked was what happens when you give the vaccine either alone or when you deplete Tregs. And so this is looking at depletion in the spleen with our Treg depleting therapy, and this is the vaccine alone. And this is the number of CD4 FOXP3 T cells. This is giving Treg depletion. We do a pretty good job in the spleen. Interestingly, not as good in the pancreatic lymph node, but we still get about half. And it's harder to look in the pannins, very hard to look at pannins, very small amounts of tissue. There is some decrease, but we could never get a significant decrease. But we seem to at least get a systemic decrease. Importantly, we do see a survival benefit in these mice when you give vaccine plus Treg. I think I've lost the pointer. Anyway, you could see the higher graph shows you that about 40% of the mice live long term when you give the vaccine plus Treg depletion versus only about 10% when you have just vaccine. But here's what was really interesting. Oh, here we go. So when you look at giving the vaccine at less than 2 months at the time of Panin-1 development, what you see is you get a significant difference in survival of the combination versus vaccine alone. If you now give it at the time of Panin-2, 3, you lose that. So obviously, we're going to need to try to target a driver gene type target very early, and this is really going to depend on screening individuals, or we need to be able to modulate some of the other populations that may be suppressive along with Tregs in order to get a better response. We also looked pathologically, and this is work done with Bob Anders, who's the pathologist who works with us, and you could see looking at mice that received no treatment. By the time we get to about 2 months, we have Panin-3s and cancers developing. Same thing for vaccine only, Treg depletion only, but not when you give the vaccine and Treg depletion. So it correlates with what we saw with survival. So we did want to see what was going on in these pannins, and so we were able to isolate tumor or T-cell infiltrating lymphocytes that infiltrate the pannins, and we're able to purify them and look at them by flow cytometry and PCR. And what we saw, this is comparing immunohistochemistry with flow cytometry, and you could see that with combination therapy, we see both CD4 infiltrating and CD8s. Very few when you just have vaccine alone, and when we quantitate, you could see again, the numbers are significantly higher in both the CD8 and the CD4 FOXP3 negative population. And they seem to be effector memory in these populations, so the percent of CD62 ligand low, CD44 high on CD4s, and CD8s is higher again in the combination. And also important, often when we look at T cells that are induced in patients with cancer, they're still not as functional as a virally targeted T cell. And when I say that, usually they're not polycytokine secreting, and you really want to see a polycytokine secreting T cell. Well, what we do see here in this prevention setting, when you do deplete the T regulatory cells, is you do see polycytokine, you see the gamma interferon. Interestingly, we see an IL-17 response, which can be pro-carcinogenic, but it can also be anti-cancer and is often part of an autoimmune process. And you can see that the transcription factors for CD4 interferon gamma, Tbet, and the transcription factor for IL-17 are also up. And they're also polycytokine in that they're secreting TNF-alpha, which is very important here. You could see, and these are the number of T cells per milligram of pancreas. And again, this is the transcription factors that correspond with the cytokine production. So what are the next steps? So we went after Tregs because at the time we had some Treg agents that could deplete them, but we really do need to look at some of those other early infiltrating populations. We also want to look at ways that we can modulate that will not be toxic. So we really don't want to be giving an anti-CTLA-4 antibody with vaccine in patients who are healthy. Again, as some of the speakers mentioned this morning, you have to balance what you're doing in a healthy individual. So one of the areas that is an area of high investigation has been to identify epigenetic regulators of the myeloid function. And these are some of the areas that we and others are pursuing. And eventually, we want to develop combinations that will alter the tumor microenvironment along with targeting a driver gene. Now, the one thing about this is we don't suspect you're going to need long-term therapy. So the amount of toxicity we hope will be minimized too by the length of exposure. So I'm going to conclude with just a few key points. So immune suppression occurs early in pancreatic cancer development, very important. Screening and early detection should identify pre-malignancies early in their initiation at the time of driver gene activation. Vaccines should be able to induce immune responses that target driver genes, but again, we're probably going to have to also manipulate or alter the functional polarity of some of the infiltrating inflammatory cells. So the challenge right now is also to identify those high-risk populations early when there are a few developed resistance pathways, as I showed you in one of the slides. Again, the earlier we target, the less immune resistance we have to modulate. But even so, again, vaccines for prevention, when we're talking about cancer prevention for non-virally expressed tumors, are going to require reprogramming of early inflammatory cell populations in order to favor a pro-malignancy, a pre-malignant immunity. And so I will stop there, and I will just mention some of my scientific partners in this. Again, Ralph Ruban and Bob Anders are pathologists who have worked with us, and I think I mentioned the graduate student, Bridget Keenan, whose work this really was. Thank you.